Good morning to all. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine and the Principal, PaO2 Institute of Medical Sciences. Today I will be discussing on cyanosis, hypoxia and hypoxemia. Cyanosis is bluish discoloration of the skin or mucous membrane due to increased amount of reduced hemoglobin or abnormal hemoglobin. Most often, the etiology is cardiac or respiratory disease, and approach depend on a good history, clinical examination, and necessary investigations. Cardiac causes can be easily diagnosed by an echocardiogram or Doppler studies, and lung problems usually diagnosed by history, examination, and radiological evaluation. And hypoxemia is determined by pulse oximetry and EBG analysis. Cyanosis is seen in literature from time of Hippocrates. It was called morbus ceruleus, and it was Morgagni who described cyanosis in pulmonary stenosis, and later Bernard found the difference between arterial and venous blood by looking into the blood gases, and Lensgaard quantified the amount of reduced hemoglobin required to produce cyanosis. Again, remember, it is a capillary level, not the arterial level of reduced hemoglobin that identifies the cyanosis. The bluish color of the venous blood is due to reduced hemoglobin, and in the arteries, lesser amount, more than 3 grams of reduced hemoglobin can produce cyanosis. Second point to be remembered, it is not the relative quantity but the absolute quantity. For example, a patient with anemia and hemoglobin 9 grams, 5 grams of reduced hemoglobin is required to produce cyanosis, and so the appearance will be very late, or even without development of cyanosis, patient can be severely hypoxemic and die. So looking into this child, you can see the mucosa is bluish in color and hands are also bluish. So this is central cyanosis. And in central cyanosis, as we have already mentioned, it is high amount of reduced hemoglobin. 3 terms you should know. One is cyanosis, second is hypoxemia, and third is hypoxia. Cyanosis we have defined. Hypoxemia is the reduced amount of oxygen in the peripheral blood, that is in the oxygen in the blood. Hypoxia is at the tissue level. For example, a patient can develop hypoxia without hypoxemia at the tissue level. When the coronaries are blocked, the heart is having hypoxia, but the oxygen level in the blood can be normal. Hope these 3 terms are clear to you. So the first cause for cyanosis is reduced hemoglobin level is increased in the blood. That is hypoxia or hypoxemia in the blood. Second cause is abnormal hemoglobins like sulfhemoglobin and methemoglobin. Coming to the cyanosis, cyanosis can be central. That is when the mucosa is affected is central. In central cyanosis, there will be definitely peripheral cyanosis also. Peripheral cyanosis means only the extremities, the hands, the legs, tip of the nostril or the earlobes are cyanosed. The mucosa is not cyanosed. When the mucosa is cyanosed, it is central cyanosis, and in central cyanosis there will be definitely peripheral cyanosis. Pseudocyanosis, it is due to abnormal pigmentation. This can occur in certain drugs like mepacrin, amiodarone, silver, and gold. Differential cyanosis is cyanosis occurring in the one extremity, that is lower limbs, with upper extremity spared. It is called differential cyanosis. Sometimes we can get a reverse differential cyanosis. That is, upper limbs are cyanosed and lower limbs are not cyanosed. A very rare condition. So this picture shows pseudocyanosis. This is due to pigmentation occurring due to drugs or chemicals like silver salt. It is called argyria. When it is called gold salts, it is called chrysiasis. So we have mentioned about differential cyanosis. In the classical setting, differential cyanosis means lower limbs are cyanosed and the upper limbs are not cyanosed. This is typical of reverse flow shunt occurring in patent ductus arteriosus. That is, here you can see the ductus is getting connected to the pulmonary artery, and when the shunt is getting reversed, that is, from the pulmonary system, blood goes to the aorta. So what will happen? In the aorta, you will be getting the oxygenated blood from the left ventricle. It goes to the face and upper limbs, and the ductus is connected below the subclavian artery on the left side. So lower limbs get cyanosed, so you can get a lower limb bluish. This is called the differential cyanosis. So basically, our idea is to identify central cyanosis and peripheral cyanosis, how we can differentiate it. Central cyanosis is generalized, that is, mucosa is affected, extremities are affected. Tongue is involved always in central cyanosis. Or you can say the tongue is involved, it is central cyanosis. Extremities are warm, whereas in peripheral cyanosis, it is cold. Clubbing, if present, it is central cyanosis. And supplemental oxygen will correct the central cyanosis if it is due to pulmonary cause. Immerse the hand in warm water. So what will happen? In central cyanosis, there may not be much change, but peripheral cyanosis get improved. What's the reason? Peripheral cyanosis is due to stagnation of blood. That is, more time is taken for the blood to travel. So more oxygen is extracted from the peripheral blood, and that leads on to cyanosis. So in such case, if you immerse a hand in warm water, circulation improves and the cyanosis decreases. Then look for the capillary refill time. It is increased in peripheral cyanosis. This can be remembered by a small acronym, cold palms. See, peripheral cyanosis, cold, and central cyanosis, palms. So central cyanosis can be due to polycythemia, high altitude, lung diseases, methemoglobinemia, and shuntations. Peripheral cyanosis, of course, cold, any obstruction, heart failure can lead on to peripheral cyanosis. Let us look into the mechanism. It can be either due to hypoxemia or abnormal hemoglobins, like sulfahemoglobin or methemoglobin. In central cyanosis, that is hypoxemia, the partial pressure of oxygen by ABG is less than 60 millimeters of mercury, which in normal cases more than 95 usually. And partial pressure of oxygen by pulse oximetry is less than 85. That is, in central cyanosis, the partial pressure is low, the SpO2 is low. So let us look into mechanisms of production of hypoxemia. Here you can see there is ventilation, there is perfusion. There is a ventilation-perfusion mismatch that can lead on to either the perfusion is decreased or ventilation is decreased. Second is decreased diffusion, that is gas exchange is not occurring. There is a abnormalities in the lung or the alveoli that leads on to impaired diffusion. Or decreased oxygen in the alveolus, that is, it can occur in high altitude. Or shunting, which can be either at the level of the heart or at the level of the lungs. So shunting, that is intracardiac or in the intrapulmonary shunting. You might have heard the term blue bloater and pink puffer. In COPD patients, when they develop heart failure, they can develop cyanosis. It is called a blue bloater, that is, they are bloated up due to the heart failure. So regarding ventilation perfusion mismatch, the common conditions are obstructive lung disease, pulmonary embolism. Impaired diffusion occurs in pulmonary fibrosis. Shunt lesion I already mentioned. It can be intracardiac shunting, that is congenital cyanotic heart disease, or an Eisenmenger syndrome, that is reverse flow shunting, that is occurring. Can be due to In the lungs, the alveolar collapse can lead on to, that is shunting, or it may be due to pulmonary AV malformations. So regarding hypoxemia, hypoxemia means the oxygen tension in the blood is decreased and is analyzed by the ABG. So regarding pulse oximetry and ABGs in cyanosis, in central cyanosis both are abnormal. That is, pulse oximetry and ABG will be abnormal in central cyanosis. In peripheral cyanosis, partial pressure of oxygen is usually normal. PaO2 by ABG analysis is normal, and the pulse oximetry can be decreased or falsely low because of the decreased perfusion occurring into the extremities. So what is pulse oximetry? Pulse oximetry is based on the principle of differential absorption of oxy and deoxyhemoglobin when infrared and red light is passed through the fingers, or you should not get confused with the SpO2 and PaO2. SpO2 is the saturation of peripheral oxygen determined by pulse oximetry, and PaO2 is the oxygen tension in the blood determined by ABG. Look at the oxygen dissociation curve. Because of the sigmoid shape, only when or even when the partial pressure of oxygen is 60, the SpO2 is 90. When it reaches less than 85, only you get cyanosis, and at that time the partial pressure of oxygen is significantly low. That is, the normal partial pressure of oxygen is 70 to 100, whereas the normal SpO2, that is pulse oximetry values, are between 90 to 100. And when the SpO2 is less than 85, only you get cyanosis. As we have mentioned earlier, abnormal hemoglobins like methemoglobin can lead on to cyanosis, and in the ICU this may be considered as refractory hypoxemia because the pulse oximetry SpO2 will be in the 80s, usually between 82 and 86, even when the partial pressure of oxygen in the blood by ABG is high, and this may be considered as refractory hypoxemia unless this is kept in mind. In methemoglobinemia, the iron in the hemoglobin is in the ferric state, and so strong oxidizing drugs like dapsone, nitroglycerin, etc. can lead on to methemoglobinemia. This can be congenital, as in case of enzyme deficiency cytochrome B reductase. Now look into how to approach a patient. In the beginning we have discussed cyanosis can be mainly due to diseases of the heart and lung, and so history is very important. The vitals, suppose the pulse is low, BP is low, it may be due to shock, and the fever is there, it may be due to sepsis. So a good history is very important, and basically we'll be looking at what is the time of onset of cyanosis. If it is from early childhood, it is likely to be due to congenital cyanotic heart disease. In Eisenmenger syndrome, it can occur later in heart disease. Second is it central or peripheral? And also you should rule out pseudocyanosis, about which we have described. Third is look for whether there is clubbing is there. Finger clubbing plus cyanosis is indicative of central cyanosis and is often due to congenital heart disease. One of the lung condition that we can get is the interstitial lung disease. Then you look at the arterial blood analysis, ABG and pulse oximetry. ABG and SpO2, that is pulse oximetry, both are low in central cyanosis. If pulse oximetry is indeterminate, perform co-oximetry to identify abnormal hemoglobins. The rest of the way how to approach a patient has been discussed earlier. Regarding finger oximetry or the pulse oximetry, Here we can see infrared and red light is passed through the finger. Differential absorption helps in identifying the amount of oxyhemoglobin. The details of which will be discussed in the next session. So we have discussed various types of cyanosis, that is central cyanosis, peripheral cyanosis, pseudocyanosis, and differential cyanosis, and how to differentiate them, and a few words on oxygen dissociation curve, and phyllosine looking in SpO2 for diagnosing cyanosis. Hope this was beneficial to you. If you like this, share the channel and give comments about this. Thank you. We'll be coming with pulse oximetry in the next session.